Tiago team. Yes, we will send the email. Yes. I know Elliot.
Yes, he's my boss. So he's my leader.
Yeah, I've worked with the CEO before World Cup Assembly. Thank you so much. Yeah. No, thanks for coming. We're very happy to have you. Thank you.
Maybe not the best.
So, Maki, I keep two seats for staff. Perhaps you could sit there. Yeah.
Yeah.
We already have some questions.
already have questions. Wait, should I ask? I was going to ask you for the questions in the audience.
Yeah.
I think we should prioritize.
Yeah, so the Maki and the Tiago will screen the questions and then give it to you.
And how about for the live feed? I will just have to select based on hands, right? Like this one.
Yeah.
And then so the team will
Yeah.
take microphones
Yeah,
there
yeah.
and ask, and then
Yeah.
somebody will write the questions for Team Evans to answer. Or he can write it himself.
Yeah. But then the question to the team is from the live stream, right?
Yes. So
Not from the.
no. So
Yeah.
basically, all the four people
Yeah.
will be asking questions about UHC and whatever questions they have, and also about the presentations.
Yeah.
And Tim will try to.
This is for you.
Anyway, I should let you get on with your...
David. Yeah.
Talk to Jack and we'll try and talk them through procedures.
So shall we do that? Shall we start getting?
I'm doing it like one by one, but if you could just open my.
So good evening. It's great seeing everyone here. We will have to start in a few minutes, so can you please find an empty seat and get seated. Thank you. Est-ce que je peux t'aider à demander à vraiment essayer de ramener les gens dans la salle et qu'ils puissent trouver... So, good evening, everyone. I'm Natalie Pahonyotin, Associate Director at the Rockefeller Foundation, and I'm honored to be your moderator for this evening's event, UHC Day, Act with Ambition. I see many familiar faces and many new ones. And this event is also broadcasted live via our webcast. And so I extend a very warm welcome to everyone here virtually and also physically here. Today, we celebrate UHC Day that marks the anniversary of the United Nations' historic and unanimous endorsement of universal health coverage in 2012. UHC Day is widely celebrated, and it is possible because of the UHC Coalition, comprising of 844 organizations from 117 countries. This year, there are over 80 events in 33 countries, and we are among one of these events occurring simultaneously around the world. So with all of us gathered here and in other capitals in the world, everybody is standing up for UHC. Political leadership, commitment to deliver, accountability to the people, and working together towards this shared goal are now more than ever necessary through the IHP Plus UHC 2030 platform. Before I invite our opening speaker, who will speak on dedicated leadership to improve health for all, I would like to make two quick reminders. The first reminder is to our followers on webcast. As you listen to the presentations, please think about your questions and send it via our Twitter feed with the handle #AskUHC2030. To all of those who are here tonight, please think about your questions as we go through with the program. And also there are biographies on the seats where you can actually take a look at the details of the speakers. So with no further ado, I would like to invite Honorable Professor Piasakul Sakon Sathayathorn, Minister of Public Health of Thailand, to share his opening remarks.
Excellencies, ladies and gentlemen, today, December 12, 2016, we commemorate the UHC Day. 4 years ago, on December 12, 2012, or 12-12-12, the heads of states unanimously adopted the United Nations General Assembly resolution on universal health coverage, which turned into the adoption of SDG 3.8 on UHC last year. Now, we must move seriously to make UHC a reality. Thailand started to cover the poor in 1975 at a GNI per capita of $390 and achieved full population coverage in 2002 at the GNI per capita of $1,900. It's the time when we were at the bottom of GNI per capita from the year 1997 ASEAN economic crisis that stimulated us to realize that because we are poor, we cannot afford not to have UHC. Please, this is a remark. Because we are poor, we cannot afford not to have UHC. Thailand adopted tax-financed UC scheme to achieve UHC against the experts' advices for contributory scheme. It is extremely difficult for developing countries to achieve full UHC based on contributory scheme, as it is very difficult and costly to enforce payment or contribution from the informal sector. A comprehensive benefit package is possible through adopting a closed-end payment based on capitation contract to primary care gatekeeper and DRG-based payment with global budget for inpatient care. This is against international experts' advice on the use of fee for service to satisfy the providers and also provides free choices of care to the citizens. History proves that external experts' advice to developing countries are not always applicable, as they are not familiar with the political, social, and economic context of each country. Countries must develop their own capacity in steering and implementing USC and refrain to rely solely on external experts' advices. The Thai Ministry of Public Health has demonstrated the capacity to establish, maintain, and manage quality public health services, especially in the provincial settings, which ensure the universal access to essential health services. The National Health Security Office has demonstrated the capacities on strategic financial supports, which improve equity and efficiency, and has become a global role model. The close collaboration between the two agencies is most essential to ensure the success of USC. Published evidence demonstrated that Thai UC scheme favorable outcomes. The utilization of ProPoor as a result of extensive geographical coverage of primary health care with good referral systems. The incidence of catastrophic spending and medical impoverishment was extremely low. Excellencies, ladies and gentlemen, only increased countries' sustainable capacity on USC can allow us to come back and celebrate the success of USC in December 2030. It is the country capacities that translate political intention into sustainable USC with good outcomes. It is therefore the development partners' moral obligation to strengthen sustainable country capacity, that is to build their capacity to fish, not only give them the fishes. This must be the primary goal of our USC 2030. Thank you for your kind attention.
Thank you very much, Minister Piyasakul. Our next speaker will be joining us via a video message, Dr. Margaret Chan, WHO's Director General. So let us listen to her message together. No, that was not her message. It's coming. Okay, I think we have it figured out. Oops. We tested it and it worked. Is it not working? Oops. So why don't we start? Okay. So what I propose that we do is we could listen to her message once the technical issues are resolved, and maybe we can invite Dr. Agnes to speak. But 1 second, let me check. This will affect the PowerPoints, though, right? Okay. So excuse me for the technology glitch. Let's do a small reversal of order because the first speaker will need to use the screen. So let us meet with the speakers. So right here is Dr. Agnes Suka, who I believe needs no introduction. She is the Director of Health System Financing and Governance at WHO. Our next panelist is Mr. Simon Wright, Head of Health Policy and Advocacy at Save the Children. Our next panelist is Mr. Dana Hovig, Director of Integrated Delivery at the Bill and Melinda Gates Foundation. And our fourth speaker is Mr. David Weekliam, Chair of the Global Health Workforce Network. Oh, and great, we have great news, it works now. The importance of being resilient, I guess. Great, so let us watch Dr. Margaret Chan on video together.
Greetings from the World Health Organization in Geneva. Another turbulent year approaches its end. We have faced outbreaks of Zika, yellow fever, and cholera, conflicts in Iraq, Syria, and Yemen, and earthquakes in several countries. Every one of these events reminds us that the best defense against sudden shocks to health is universal health coverage. Universal health coverage is a wise investment for other reasons, ensuring that everybody receives essential health services without experiencing financial hardship, contributes to social cohesion and stability, and furthers the goal of ending poverty. Universal health coverage is understandably a major health target among the Sustainable Development Goals. I have been encouraged to see so many countries at all income levels across different regions of the world making good progress towards UHC. UHC is not cheap, but it is affordable when the right decisions are made. Strengthening any health system must begin by investing in good primary health care services. Being able to reliably measure progress is one of the best incentives for continued investment. Last month, the group that advises on tracking progress towards the Sustainable Development Goals adopted two measures for UHC. One monitors access to essential health services. The other measures the financial impact on households of out-of-pocket expenditure on health. Many countries already have data on both indicators, but some gaps need to be filled. WHO and its partners are working with countries to strengthen their health information systems as the foundation for smart and successful policy decisions. This is the last UHC Day I will celebrate as Director General of WHO. I wish my successor every success as WHO continues to support countries in their journey towards UHC. People deserve decent and affordable health care. UHC honors that right. Thank you.
After those inspiring words from Minister Piasakon and Dr. Chan, let us turn to the panelists. Panelists, you have 5 minutes to answer to the following question. How has your organization contributed to accelerating progress towards UHC under the 2030 agenda? 5 minutes. Thank you.
Thank you very much. Today is UHC Day, and hopefully 15 years from now, we will be celebrating the achievement of UHC globally. Next. Or do I have a... If you don't do it, I'll do it.
It's not working. Well, we'll do it from here.
Not working either.
Ça doit marcher.
Obviously, Geneva is not the capital of technology.
Wait a second. What's wrong with this?
Should never use a WHO computer for a public presentation. Maybe you say to the next person.
This person also has a presentation. So maybe we go to those without the maybe you should go to those without the presentation for the sake of time. And I'm looking at Mr. Dana Hovig, again from the Bill and Melinda Gates Foundation. Perhaps you would like to respond to my question, and especially on how primary health care is a critical piece towards achieving UHC.
Great, thanks, Natalie. And thanks to the International Health Partnership for UHC 2030 for convening us here, and as we strive to make health for all a reality, a goal that the Foundation and I are proud to support. I want to focus on the urgent need for strong primary healthcare systems to achieve health for all on the path to UHC. And I also want to talk briefly about the Gates Foundation's commitment to improving primary healthcare systems on the path towards universal health coverage. We know that primary healthcare is people's first and main source of care. When effective, it's a one-stop shop for mothers, for kids, for families. And we also know that it can manage about 90%, that's right, 90% of all population health needs. We know that primary care is pro-poor and pro-prevention, and as such, it aligns exactly with the Foundation's fundamental values and beliefs that all lives have equal value. So we've seen at the Foundation, and you've all seen the benefits of supporting strong primary health care across countries from Thailand to Ethiopia to Costa Rica to Chile. And we know that countries that have invested in primary health care have really set themselves on the path towards universal health coverage, and to do so efficiently, cost-effectively, and equitably. And yet we know that gaps still remain, and probably one of the most important gaps in health systems overall is the gap that 400 million people face every year. 400 million people lack access to essential primary health care services, and we know that millions more than that lack access to quality care. At the Foundation, we're new to this space, and yet we've already identified and have a couple of partnerships we're proud to talk about. We've identified two major barriers to effective primary health care on the path towards UHC. First is the lack of funding for primary health care, which really fits, I think, with WHO and UHC's call for smarter and more effective money. Sure, we all want more money for health, but first and foremost, we need smarter and more effective money. The second barrier that I want to talk about briefly is the lack of data, as others have mentioned. a new analysis that the Foundation and WHO has done of the system of health accounts has highlighted that 31 lower middle income country governments spend on average only about 1/3 of their domestic health spend on primary health care. The other 2/3 of that domestic spend goes to tertiary care and specialty care. So in effect, that's 1/3 of spend for a system which can deliver 90% of all healthcare services to improve population health. We also know that out-of-pocket payments from this analysis in these 31 countries make up close to 60% of all primary healthcare spending in these 31 countries. We know that out-of-pocket expenditure, as was mentioned earlier, is both a barrier to care, but it also is a reason that families fall into poverty. I want to talk about 3 ways that data is also a problem. And I want to particularly talk about data and trend data. I used to manage a complex adaptive organization, and it wasn't snapshots of data that really mattered to me. It was trends in data over time. And we lack trends in data in 3 important areas. First, as I mentioned briefly before, very few countries regularly track their health spend and primary health care versus tertiary health care expenditure. Second, even fewer countries track important service delivery questions. For example, very few countries can say for their health system whether their providers are present and whether their providers are accurately diagnosing patients. And third, and I think most importantly, no lower middle income country or middle income country has a robust measure that tracks whether their health system is getting stronger and more resilient or not. I think this is a major gap in our work and frankly in our community. How can we ask donors and host country governments to invest in health system strengthening if they don't have a simple measure that they can trend over time of whether their system, not just outcomes, but their system is getting stronger or not? So these are major challenges, but we at the Gates Foundation are excited about today, UHC Day, and the growing political will around this community. We're also excited about a couple partnerships that I just want to briefly mention. Last year, the Foundation, WHO, and the World Bank launched the Primary Healthcare Performance Initiative, which is a partnership that seeks to strengthen and improve primary healthcare, starting with better measurement. The Primary Healthcare Performance Initiative also has joined forces and is working with the Joint Learning Network, which is a country-led network of practitioners and policymakers that translates data into evidence and into action. We know that the answers to health system strengthening and universal health coverage and primary health care improvement are not in Seattle or in Washington, D.C., or even in Geneva. They're really in the hands and the minds of practitioners on the front lines doing the hard work day to day. So we're excited about these partnerships. We're excited about today, and we're excited about the commitment and the political will around this fundamental right of health for all. Thank you, and we look forward to listening and learning from all of our partners because we are new to this space and have much to learn from all of you. Thank you.
Thank you very much, Dana. Simon, would you like now to say a few words about how your organization, Save the Children, is helping towards accelerating progress for UHC?
Thanks very much, Natalie. Thank you, everyone, and Minister. It's great to have you here as well. As everybody knows, you don't need me to tell you that 2016 has been a year of some momentous seismic changes which are going to reverberate for decades. I think of a few. One is the G7 summit, where for the first time the richest countries supported universal health coverage. Another is the victory that we had on target 3.8.2, the indicator on financial risk protection. Some good old-fashioned NGO campaigning helped to push, as well as the expert advice from organizations like WHO, helped to push getting a proper indicator that really will measure financial risk protection. I should say one big change is having the Gates Foundation actively participating in UHC Day. That wasn't the case a year ago, so that's great. And also, I think us being able to take part today in one of what are kind of multiple events towards the kind of formal launch of UHC 2030. So there's a lot of real positives at the end of 2016. Maybe it's lucky that UHC Day comes at the end of the year. But there are a lot of negatives and a lot of obstacles ahead as well around achieving target 3.8. Donor aid, we know, is pretty much stagnating. I'm from the UK. In the UK, we've just seen that last year, DFID's bilateral spend, health fell from number 1 to number 4. Not sure whether that's a one-year change or As Dana said, we need to see trends over a longer time, but it's worrying. European donors are getting diverted by the refugee crisis and starting to see the aid budget as a way of supporting those. Despite the lessons that we all said we were learning from Ebola, and everybody said they were learning from Ebola, the global health security agenda doesn't really seem to understand that unless UHC exists in a country, it cannot withstand an outbreak of an infectious disease without international help. And there has been an election in the US, whereas the US has been very instrumental in things like the G7 supporting UHC as they've been making their changes to their own health system with their new president, who knows whether they're going to be a global champion, whether they join Japan and Germany, who've been great supporters. For those reasons, I think that we need to have a relentless focus on the financing decisions that are made at national level for universal health coverage if we're serious about achieving target 3.8. And we need to challenge the idea very firmly and very forcefully that countries cannot afford universal health coverage. As the minister from Thailand has said, countries can do enormous amounts within existing resources. And we published a report, actually nearly a year ago now, called Within Our Means, where we did some analysis. And we looked at the countries with the highest maternal and child health burden. And we took the target of $86 per capita as a kind of minimum expenditure on universal health coverage and looked at what the gap is in those countries. And we took that $86 per capita not as total health expenditure, but as government health expenditure. And there's some very good reasons for doing that. We're going to hear a little bit from Dr. Sass Kagbo from Sierra Leone. Ironically, Sierra Leone in 2014, its total health expenditure in the country was $86 per capita. But the vast majority of that was out-of-pocket payments, not government expenditure, not public expenditure. So looking at the gap, we calculated that by 2030, on current trends, the gap in financing for UHC would fall to about $101 billion, which is a lot of money. And sounds like an insurmountable amount across these approximately 70 countries. But actually, if you look at a number of other targets, international targets that have been agreed or have been proposed, actually that gap isn't necessarily there. Countries should be, this is a UNDP bit of analysis, suggested that countries should be capturing 20% of their GDP into the public budget, whether through tax, whether through owning extractive industries. About 20%, a reasonable benchmark of GDP into the public budget. Many low and low middle income countries are far below that amount. And so yes, their economies are not huge, but if they're not capturing even 20% of it into the public budget, they're not doing a lot that they can do. And also, if you take the Abuja target of 15% of the government budget being spent on health, if you apply those two targets, the gap falls, just on our calculations by doing that, to $28 billion per year by 2030. 3/4 of the gap virtually filled by those governments taking those two actions. That's a very broad brush analysis, of course, but it does show the kind of decisions that can be made. We also in the report talk about the tax concessions that developing countries are giving to multinational companies, and that's calculated as about $150 billion a year is being lost through tax concessions given voluntarily by governments. That's 3 times the annual health budget for sub-Saharan African countries. So if all that was done, and it was done in the right way, and also if you improve efficiencies, you can massively close this gap just to achieve that minimum target of $86 per capita. It's not the whole story. What they do with it is really important. And I want to say we don't think there isn't a role for donors. Of course there is. That donors, if they were achieving their target, 0.7% of GNI being given as international aid, it would double the aid that was available. But it doesn't appear that donors are very serious about making changes to the way they deliver health aid. In fact, I would say they're going the other way. We're seeing them being much more interested in short-term results from project aid than the long-term difficulties of helping governments build their health systems and their health financing. And in fact, the evidence shows that it's when governments take a stand and control the donors coming into their country and are able to manage them, refuse money that actually isn't in line with the plan that they're trying to carry out, and direct money to where they do want it, that actually governments can show progress with aid. A few organizations, Save the Children, PAI, Global Health Advocates, published a blog about a week ago, and we said, given that 75% of all health expenditure in least developed countries is domestic, and only 25% is external, and the bit that needs to increase is the domestic, and in lower middle income countries, it's 97% of it is domestic, only 3% is external. We said, let's make sure we're always spending at least 3/4 of our time discussing how better to raise national resources, public financing. It's all too easy to get pulled into talking always about donors. Many of us live in donor capitals. That's kind of our day work, and of course we've got an important job to do there. But we also need to make sure that the focus, the primary focus, is on governments doing what they can, making the right policy decisions to build UHC, and then making sure that donors fall in. A secondary issue is making sure that donors fall in and support that. And there are lots of policy issues about how it's being done. How do you reduce out-of-pocket payments? How do you move to fair public financing that's raising resources in a fair way from people according to their ability to pay, that is guaranteeing universal coverage? Are countries doing employee insurance schemes that benefit those in formal employment, but actually perhaps make things worse for those who aren't? And are countries prioritizing those universal, everyday primary healthcare services that every community needs close by as the first priority of UHC? And these are the discussions that we need to be having and challenging governments to do this. And I guess we also should make sure that we're doing that through the framework of the right to health, that the universal entitlement to healthcare, it's not a product that people should hope to buy if they're ever rich enough. It is their entitlement to free at the point of use healthcare. It should be progressively realized, bringing those left behind into coverage first. And it should be non-discriminatory. It should look at what discriminations apply in the country and how those are excluding people. So it's just a call to make sure that first and foremost we talk about how governments need to take control of this agenda and make changes for themselves, and lots that can be done. Thanks.
Thank you very much, Simon, and thank you for sharing those very revealing and powerful numbers. Now let's try once again with our technology. And Dr. Agnes, would you mind trying once again the WHO laptop? Thank you.
So you see what we are up against in WHO to be effective. Our first battle is technology. So we are gathered tonight to celebrate our early achievements on universal health coverage. And I really wanted to start with how grateful we are, Honorable Minister, for your presence here and for the leadership of Thailand on universal health coverage. I think we first need to celebrate those pioneering countries who have achieved so much by just making the right political decision, as you said. We were too poor not to afford universal health coverage, and that's really the message we want to give today, even at very low level of resources. And Simon just said it as a key message from the Save the Children report. Also the message on primary health care. All countries can reach some level of universality. So celebrating achievement, another achievement at global level is that we now have very clear indicators to measure universal coverage. So we will be able to measure progress at country level, and we will be able to see how countries do vis-à-vis each other, and to be able to see whether particular policies work better than others. UHC is about access to quality essential health services without financial hardship, and that access to services is both for individuals and for communities. We're talking both about individual services and public health services. And of course, as powerfully advocated by Dana Hovig here as the Gates Foundation, good data and relevant indicators are critical to measure this progress. So when we measure universal coverage, which is target 3.8 of SDG 3, we're talking about two indicators, the coverage of essential health services and an indicator that measures the financial protection. So how health services, the access to health services, protect households and individuals from the impoverishing effect of healthcare expenditures and loss of income due to illness. So the indicator 3.81, which is the first one, the coverage of essential health services, brings together different elements because, of course, health services are very broad. There are hundreds of them. So we try to select some key tracers of service. And they are in different areas of health. One is reproductive, maternal, neonatal, and child health. Another one is infectious disease. Another one is non-communicable disease. And it also includes reference to service capacity and access. So we are developing jointly with different technical partners the index of universal health coverage, which is going to be reported annually by the WHO jointly with the World Bank. The second indicator is the financial protection coverage. And here we just reach a major achievement, a success, after an incredible campaign from the civil society to help us measure the right thing. In the initial discussions in the technical committees of the United Nations, there was some uncertainty about how this would be measured. And at some point, an indicator was selected to just measure the process. And as a community, together with the civil society and different technical organizations, the WHO advocated for an indicator of impact, an indicator to actually measure really the financial protection. That is, measuring actually the expenditure that households will incur in case of illness and relating those expenditures to the household income overall, and to see whether these expenditures linked to health, linked to an illness, to a catastrophic expenditure actually bring people into impoverishment or are at a level that creates some catastrophic consequences on the welfare of the household. So we don't just measure the affiliation to a scheme or an entitlement, a promise of entitlement from, for example, a free public facility. We really measure actually what happens at household level, how much people spend on health versus how much what their income is generally. So the indicator that now is retained, and that's really a victory of our movement and our community, is the proportion of the population with large household expenditures on health as a share of total household expenditure. So really, let's celebrate this tonight. This is really a victory of the civil society, a victory of our movement for universal health coverage. Now, today, as a WHO, we are launching the UHC data portal. So here is a snapshot of it. So as of today, all the information we have on coverage of services as well as on financial protection for every country is going to be accessible within this portal. And we are collaborating with different partners on this, but particularly the World Bank, specifically on the financial protection indicator. So as of today, you can actually go to this to the WHO website and access this portal, in which you can access the information for a specific country, but also information for regions, and you can create different types of graphics and communication tool based on these data. So the annual, the UHC global monitoring is something that has been taken on by the WHO together with the World Bank. The two institutions have been tasked by the UN system to monitor these indicators. So in 2013, a monitoring framework was developed. In 2015, this is the first implementation of this framework. So we are now working on producing the statistics, the metrics. So in 2016, the framework was institutionalized. So now it's part of the United Nations SDG monitoring framework. We have the Universal Health Coverage Data Portal, and we are right now doing country consultations to review the estimates and the methods so that when we publish them, there is full buy-in of the countries. We actually have most of the estimates now, but we want to go through this whole process of validation so that countries can feel comfortable with whatever statistics and metrics we put on this UHC portal, they are fully behind it. So as an early announcement, in 2017, we will release the new global, regional, and country estimates on both indicators, the financial protection in health and the service coverage index. Thank you very much.
Thank you very much, Agnes. And now I would like to invite Dr. David Wickleham to test the IT equipment.
Yes. Thank you. Good evening. I did come with notes, so I have backup in case all goes wrong. So I'm very pleased to be part of this UHC Day 2016, and thank you for the opportunity to speak. I'm going to give some perspectives on the health workforce. And the Global Health Workforce Network is a new network recently launched by WHO in October. So we're concerned about the workforce. No health without a workforce has been our motto. There can be no UHC without a health workforce. And currently, as you know, there's a serious global shortage, and low-income countries experience the brunt of it. So put together, global population growth, aging populations, increase in non-communicable disease, emergence of new disease threat, increasing expectations, and no surprise that the shortage is projected to increase and to reach 18 million by 2030. So how are we going to address this challenge? Or to put it another way, what can we do over the next 15 years that we haven't succeeded in doing over the last 15, or at least not well enough? So a good place to start is the WHO Global Health Workforce Strategy, Workforce 2030. Adopted by the World Health Assembly in May, it was developed through a process of analysis and consultation. And now, for the first time, we have a comprehensive evidence-based strategy for the health workforce for UHC. The vision is to accelerate progress towards UHC and the SDGs by ensuring equitable access to health workers within strengthened health systems. In brief, a health worker for everyone, everywhere. And as we're here on UHC Day, I'll say the strategy is definitely about acting with ambition. It calls for a paradigm shift to address persistent workforce challenges with transformative approaches to education and training and transformative models of care towards a collaborative primary healthcare approach built on team-based care. The strategy also calls for more fundamental paradigm shift to understand the health workforce within a labour market approach, considering the influence of labour market dynamics. We know we need to scale up the supply of health workers to meet future needs. We also need to stimulate economic demand through the creation of jobs, particularly in low-resource countries. And there's also a need for policy decisions to address the multiple labour market failures that are common today within countries and internationally. And this labour market approach enables us to see the health workforce not just within the health sector, but as part of the wider economy. And so the global strategy represents an unprecedented opportunity to implement HRH strategies to address the equity and coverage gaps faced by health systems, while also unlocking economic growth potential. And this challenge was taken up by the UN Commission on Health, Employment and Economic Growth this year, and it reported to the General Assembly in September. And there's no shortage of acting with ambition here. It aims to stimulate the creation of 40 million new jobs in the health and social sector and to reduce the projected shortfall of 18 million health workers, particularly in lower and lower middle income countries, by 2030. This can be a game changer for the health workforce in UHC. Now, we've approached the health workforce mostly through a health lens, thinking in terms of the health workers we need to deliver health services to achieve health goals. By focusing on the health workforce in the broader context of the economy and development, the Commission has highlighted the benefits of health employment across the SDGs and for inclusive economic growth. Health is a leading economic and labour sector, and the health workforce is a major part of that, making up to 11% of total employment in OECD countries in 2014. And interestingly, while jobs declined in many other sectors, health employment actually increased by 48% between 2010 and 2014. Between 2000 and 2014. And furthermore, the health sector is a major employer of women, and the creation of decent jobs will benefit women while also deriving the economic benefits of wealth creation for more women working. And while the link between health and economic growth is well established, the Commission has identified a range of additional pathways by which the workforce, as part of the health system, contributes to the economy through economic output, social protection, social cohesion, innovation and diversification, and health security. And this changes the whole narrative. With the evidence that health employment is a key pathway, not only to better health, but also to decent work and economic growth, we have a powerful case to make to governments for more expansive fiscal policies and greater investment in education and creating new jobs. And I agree with the Commission's assertion that this is a once-in-a-generation opportunity to build a sustainable workforce in all countries by 2030. This will be a key enabler of UHC and the SDGs. And this is where the Global Health Workforce comes in, the Global Health Workforce Network comes in. To quote the Commission, achieving a fit-for-purpose health workforce is an intersectoral pursuit. It requires policy decisions across many sectors of government: finance, education, health, social welfare, labour, foreign affairs, and so on. The Commission recommends intersectoral collaboration, engaging civil society, unions and other health workers' organisations and the private sector. The global strategy similarly calls for a network of international stakeholders and actors to foster effective coordination, alignment and accountability. The network was established by WHO in response to that need and call, following the completion of the 10-year mandate of the Global Health Workforce Alliance in May. It's a global mechanism for stakeholder consultation, dialogue and coordination on health workforce policies in support of implementation of the global strategy and the recommendations of the Commission. So what will the network do to accelerate progress towards universal health coverage, to answer the question posed by the moderator? Firstly, it's inspired by the strategy on the Commission, and it will act with ambition. It will facilitate multi-stakeholder engagement for UHC, focusing on aspects of the health workforce where an intersectoral response is required, such as education and financing. It will contribute to a mechanism for global monitoring and accountability on international HRH goals, targets and commitments. It will develop evidence and advocate for political commitment and action. It will participate in UHC 2030 for alignment, coordination and mutually supportive action in areas of shared interest, including knowledge management, data capacity, financing, advocacy and accountability. So on this UHC Day 2016, I'm for health workers for UHC, and I invite you to all act with ambition for a health worker for everyone everywhere, so we can achieve UHC by 2030. Thank you.
Thank you very much, David. And for the sake of time, I realize we're running a little late. I would like to introduce you to the other half of our very distinguished panel. Dr. Samuel Sheku Garbo, he's the Director of Health Systems, Policy, Planning and Information, Ministry of Health, Sierra Leone. Dr. Janet Vega, Director, National Chilean Public Health Insurance Agency, or FONASA, Chile. His Excellency Ambassador John Quinn, Permanent Representative of Australia to the United Nations in Geneva. and Ms. Priya Medina, Director, Government Affairs, Global Issues, GlaxoSmithKline. And I would like to invite Ms. Medina to maybe share some of her remarks and comments on how the private sector can be an ally towards universal health coverage.
Is this working? Yeah, it's working. Thanks very much for the opportunity to speak, and thank you, Minister, for your opening remarks. So what I was interested to hear from the first panel was all the various aspects of universal health coverage and how these can build on helping countries strengthen their local capacities. So we heard from Margaret Chan in the video about primary care and measurability. We heard from Dr. Suka about measurability and data and indicators. Simon spoke a bit about mobilizing resources at domestic level. We heard about building workforces, so a whole range of factors. And it's clear that all those are important factors. But one thing that really notably seemed missing to me was the role of the private sector. And obviously working for GSK, you would expect me to hear that. But I think one of the things that's happened quite recently is that the role of the private sector has actually now been, is kind of out there, and people are talking about it as if it is something that is important. And at the UN GA in 2015, when the SDGs were ratified, the role of the private sector was talked about really openly, not just as a donor and as an investment of resources, but also something that can help mobilize governments. So I think in that respect, the role of the private sector is very much an integral part of the Sustainable Development Goals. And we should also understand how the private sector can help these governments achieve the targets that they're seeking to achieve. So from a GSK perspective, we feel that we do have an important role in helping governments achieve this ambition. And part of our core mission as a company is to improve access to medicines. And we think that the only way for governments to achieve UHC is for all these different partners working together to mobilise those resources at local level. So some of the things that we've done are we've got a tiered pricing mechanism. We try and get access to our medicines and vaccines for those in developing countries. We do lots of non-for-profit activities, and we were just topped the Access to Medicines Index again for the 5th consecutive time. So I think my call to action would be to other companies to do similar things that we're doing, but also for other stakeholders like civil society, like WHO, to recognise that the role that we can play, obviously within a framework that's appropriate. And I think ultimately it's, given that it's governments that are accountable, it's important that there's a baseline measurement from which we can see that those gaps were to begin with, so we can see what we're working on. And I think some of those themes were touched upon in the measurability and data aspects. But I think unless we actually know what the gaps are, it's going to be very difficult to actually understand where we were and where we've gone to. So I think in summary, we would see that although governments are at the centre of the process, we'd very much like the opportunity to be part of that journey. And I think the new fortified UHC 2030 partnership is a really important way of doing it. I've seen today that there's been various discussions about all the different networks that can help mobilise UHC, and through the constituency development of the various aspects, I think private sector should be an important role. I haven't seen that discussed much today. Maybe that will be talked about tomorrow. But we definitely stand ready as GSK to lead that private sector constituency. Help galvanise, like I said, other companies along the journey, as well as work with some of our counterparts here today. Thank you.
Thank you very much, Priya. Next, I would like to turn to Dr. Samuel Cargbo, and I would like to ask you, based on your experiences in steering the health systems in Sierra Leone, could you make a few remarks on Agnes's presentation through your experiences and comment a little bit about WHO and UHC? Thank you.
Good evening. Thank you very much for this opportunity given me to speak to you here. See, my country, Sierra Leone, actually is a very small country of 7 million people, but with very big challenges that we have faced recently. We are just now recovering from the second of a very big tragedy within one generation. Just in 2002, the 11-year brutal war ended, which left the country on its knees. We thought with all the support we got from the entire world to rebuild our system, we did all our best. We thought it was good enough, but we only came to realize in 2014 when Ebola struck that our best that we did was not good enough. And this is why now we are all the more reason why we think rebuilding our health system now is of paramount importance, because this that looks like a tragedy to us is an opportunity for us to do it once and for all. And so there is a lot of action that is going on now, and the main focus is the reestablishment of services, and then, of course, the building of resilient systems, but more so looking at the financing aspect of the entire process. This is very, very important. We are moving towards, as I say, developing a healthcare financing strategy for the country. It is very, very important. And of course, with the support of the WHO and the partnership here, we are that much ahead now into getting one done. And also we have the health insurance scheme, which we are putting into place. This is very important for us because when you consider that in 2010, we introduced free health care for pregnant women, lactating mothers, and children under 5. And this has been going on, and even a recent evaluation of this with the support of Oxford Policy Management proved that it is very good, very beneficial. But then in 2013, we did national health accounts. And what came out of it was surprising to us because we discovered that 60% of the expenditure on health was out of pocket. So this was a big surprise to us, but then asking around, we knew that it was the truth. And then in 2014, but this was done actually last year now because the Ebola was on in 2014 and 2015, we did another national health account, and it came down to 25%. But upon further analysis, what we discovered that the only reason why it came down to 25% was because of the huge injection of funds because of the EVD. And so it was not encouraging to us because we know that come 2016, the out-of-pocket expenditure will still continue to rise. So this is all the more reason why, as I say, we are looking at the health insurance scheme. We are working not just as a Ministry of Health, but together with the Ministry of Labor and the National Social Insurance Trust to see that this gets underway and see that how this expenditure, how this burden can be removed from our people, because this was one of the reasons why people were not coming to the health facilities, but instead when Ebola struck, they went underground, and that was why we got the spread of Ebola. And so there are, as I say, a lot of other things we are doing now. Like, as I say, there was this fiscal space analysis that we've done and the evaluation of the free healthcare, which shows that indeed we should continue the way we are going, but then with much more emphasis on the healthcare financing aspect. Of course, there are a lot of challenges, but we're not relenting. Key among these challenges that we have is the fragmented financing that we have. There are a lot of resources in country, and we believe that all of the resources in country should be available, should be able to solve most of the issues that we have out there. But because of the fragmented financing, we are not seeing the maximum result as we should be seeing. And this is why, in as much as we did about 5 years ago the joint program of work and funding, we also did a compact, but then a lot of partners were not adhering to this. But then what we have again is a lot of implementing partners, implementing activities which we do not have control over. And so as a country, we decided to introduce what we call the service level agreement. Now, the service level agreement is like a compact, but it is at the implementing level where partners go with the districts and look at the district plans and then see what they can buy from these district plans, agree with the district that A and B and C is what they are going to deliver. The district signs on them and then sends them up to us at the directorate level. Then we look at them to see whether they are in line with the overall strategies and all, and then before it is approved by the ministry for them to implement. So this is sort of yielding some results now because we are seeing a focus on the plans that we all did together. We are seeing them being implemented now instead of everybody being on his own. So we just hope that even as it comes to national level and even at global level, this type of service level agreements that we've signed and we are enforcing that it goes the way we want to, we hope that this also can be mirrored out to the top, so that we are able to hold partners accountable into whatever resources are put in or how those resources are used. Because for all of us, I believe we have one goal, to see that health improves. So there is no reason why we should just see things go the way they do not, or just turn a blind eye when we know that it is possible that all of the resources that are going in are enough to change the health situation in our respective countries. So we look forward to the synergy as prescribed even by the 7 behaviors of the IHP Plus, and we hope that going towards the UHC 2030, we all will be able to get there and we will rejoice. Thank you very much.
Thank you very much, Dr. Kargbo, for sharing Sierra Leone's experience. I now would like to turn to Dr. Janet Vega for you to maybe share a little bit about the Chilean experience, especially with regards to primary health care, and also maybe in relation to what Dana had mentioned about the Bill and Melinda Gates program. Thank you.
Thank you, Natalie, and thank you, Dana, for your remarks. Globally, we know over 400 million people lack access to essential health services, but what is important here is that most of those services could be delivered through primary health care. We know that primary health care should be the first contact with the health system when a medical needs arise. However, that's not the reality in most of the countries, I would say in several of the countries, because there is a lack of a comprehensive network of primary health care centers or a system that allows that to happen. Primary health care allows long-standing personal relationship between the people and practitioners and the citizens. It also, well implemented, provides integrated services by introducing promotion, prevention, and social support in addition to curative care. And also, it addresses the health problems of individuals within a broader context, being that the families or the communities where they are from. We welcome the renewed interest of the Gates Foundation on primary health care. We in countries expect that the work of the foundation contributes to an inclusive primary health care with a system thinking approach more than perhaps delivery mechanisms for drugs, medicaments, or other things. We agree that lack of funding is an issue. However, there are countries like my own where even though we spend less than 30% in primary health care, we have been able to achieve some remarkable success in the area, in particular in the area of maternal and child health and nutrition, that are very dependent on a good system of primary health care. This is not only about funding, this is about a delivery system that allows, that is close to the people and close to where people live and work. If there's no delivery system, even if you get the finances right, it won't happen. Out of pocket, it's an issue also, it's an international issue. But I would say that perhaps it is more an issue for tertiary and secondary care than it is for primary care. Almost all countries in the world have some sort of protection, at least for mothers and children, to get some essential services. I can't agree more that data is a major gap. We know that data in Africa, for example, we don't even have vital registries in place, let alone other TI systems. If we are not even able to measure when people, or to count people when they are born and when they die, it's very hard to advance on primary health care or in any other health initiative. I would like to raise one final comment. I do think that there are other challenges that are as important as the challenges for the primary health care level now. And those are the challenges of what is the primary health care level or primary health care system that we need for the future. If we think 30 years from now, what is what we need? And I really believe that the primary health care level will be much closer to where people live, much closer to households, much closer to workplaces, much closer to where people do their shopping, for everything, for everyday life. And in order to really take advantage of that, we need to rethink what the primary health care level is. We need to rethink what is the right mix of technology and coaching when we are dealing with an aging population with mostly chronic diseases, 5 in average after 50 years of age, that will be living 90 years. And I think it's a big challenge. We need to think, how are we going to incorporate technology and more sophisticated drugs that are curative for diseases that have a high prevalence and that can be dealt in primary health care. The latest example that I can say is the example of hepatitis C, which we know there is a curative treatment now, and we are struggling on how we introduce that in countries with a high burden of disease. In summary, we really look forward to the contribution of the Gates Foundations, and I have to say that we have great expectations from your support to the global and countries in the world. We believe that with your support, the health community can leapfrog strategies to quickly advance in this strategy and the vision of primary health care as stated in Alma Ata in 1978, Health for All. Thank you.
So muchas gracias, Jeanette. We have a lot to learn from Chile, and so thank you for sharing such rich experiences from your country. Now I would like to turn to Your Excellency, Quinn. Would you like to maybe share with us how Australia's foreign aid programs are supporting transition and sustainability in the context of UHC? And also, could you provide maybe some points to answer to Mr. Simon Wright's remarks on donor funding? Thank you.
Well, thank you, Natalie, and distinguished minister, panelists, distinguished colleagues. Let me say how delighted I am to be here today to celebrate Universal Health Coverage Day, which I think is also a great opportunity to reflect on the importance of universal access to quality health care for every person in all communities. Let me say it's particularly a pleasure to be in such a multi-stakeholder panel, because I think, as has been made clear, the civil society, the private sector, government, international organisations have to play their role. And I think the Sustainable Development Goals have certainly put wind in the sails of UHC in Geneva. I work across many issues, and I think people are very focused now on systems. And I recall one colleague saying one critical element of SDGs was actually recognition of the private sector. So I think we are in a good place in terms of looking at these issues in a more systemic way. I wanted to say a few things, I guess, from an Australian point of view with an Asia-Pacific perspective, because I think it's an interesting story. Clearly, there are challenges, not insignificant challenges. In our region, for example, some of the world's fastest growing economies, but also inequality is growing very quickly as well. And many countries are still struggling with chronically weak health systems and limited resources. So I think we can see the curate's egg, good in part, bad in others. But clearly also I think what's apparent from our region is with sufficient political will, the right technical assistance, many countries have been able to make very good progress towards universal health coverage. I think Thailand is an outstanding example, so it's wonderful the Minister could be with us today. We've run a few events in Geneva on this subject over recent months, and a lot of interest in what's happening in our part of the world. Now, clearly a one-size-fits-all approach doesn't do the trick, but there are, I think, some common lessons we've learnt in our region, and these are, I guess, obvious, but they're worth restating. One, of course, is the imperative of strong political leadership. We need that as a starting point. Also, of course, a significant increase in domestic budget allocations for health. I think Director General Chan talked about a wise investment, and the Minister talked about can't afford not to invest in this topic. I think we need to find some nice buzz phrases to make this point. This investment is wise and prudent. Also, I think we need to focus on efficiency and effectiveness, as well as prioritisation to use scarce resources and maximise health impacts. And clearly the quality of healthcare can't be sacrificed in this process. And we've had a conversation today about the importance of data and evidence-based policy. We clearly need to have that data. Equity inclusion as a last point needs to be front and centre of policy, and clearly the SDGs talk about no one being left behind. So we have to focus on the vulnerable and the hard to reach populations. And again, comments been made about localisation, pushing down the effort to the front line, which was clearly a lesson in Ebola where the community organisations played such a critical role. Clearly, for Australia, we're very focused, making a concerted effort to focus on strengthening health systems in our region, which of course then contribute to universal health coverage. So strong and resilient health systems not only help meet the needs of populations, but also protect our countries and our regions and the global community from health security threats such as pandemic diseases. So it's a fundamental element in the global strategy on health. Perhaps I can just say a few brief things about sustainability and transition. I think Dana talked about trends. We're very interested in trends in our region. Our region is facing demographic and health financing transitions. Clearly, in many countries, populations are ageing, resulting in higher rates of chronic disease, which place major demands on health systems. At the same time, per capita domestic spending on health is rising, while external health financing levels are reducing, the so-called health financing transition. So there's a real risk of funding shortfalls for health if this transition is too rapid. So I think we're very interested in a more focused conversation about graduation, how we manage graduation from eligibility for finance from global health funds. These transitions need to be carefully managed by countries and donors alike as we sustain progress towards UHC. So clearly, again, there are some messages, I think, in this vein. We have to increase domestic investment or other financing for health to fill those funding gaps. We also have to focus on integration of UHC planning, management of externally funded health programs into government systems. So this is a conversation with finance ministries, other ministries, not just health ministries. And obviously donors and other development partners need to take a coordinated and systems-wide approach to reduce fragmentation that's been referred to and ensure sustainability in the long term. I think in that vein there's a lot of interesting conversations in terms of South-South dialogue on lessons to be learnt on transition. So in a very specific way, what we're doing as Australians is basically trying to support countries in our region addressing transition challenges. We're investing in the World Bank Multi-Donor Trust Fund for integrating donor-financed health programs. This is basically designed to help countries strengthen health systems to contribute to UHC, particularly focusing on supporting financial institutional sustainability of externally financed health programs by integrating them into country health plans, systems and budgets. This fund also supports health finance system assessments with deep dives into funding for immunisation and other vertical programs, technical assistance for capacity building, and also transition planning. Of course, sharing country experiences and best practice on implementation. So there's a very practical dialogue taking place about how we manage those transitions. So we work very closely with our partners in trying to maintain investments in our region in health systems and protect the gains that have been made, particularly against infectious diseases. So as I say, our particular focus is strong and resilient health systems, efficiently managed and sustainably financed, which go hand in hand with a safe and secure region and globe. So clearly this is a particular focus of our activity. It meshes with the Sustainable Development Goals, and I think as has been flagged today, we need some new ways of working with donors and multilateral partners to increase our focus on partnerships, coordination, harmonisation and alignment, and also a shift from supporting vertical programs to supporting country-led efforts to build strong and resilient systems for health, able to efficiently, effectively deliver a full range of health services. So I think our strategy is very focused on systems, on resilience, on system-wide focus on these issues, and I hope that will provide focus for more conversation. I'm conscious I'm the last speaker, so I should leave it at that. Thanks for your attention. Cheers.
Thank you very much, Your Excellency. Now in this session, it's going to be interactive. So I will ask 2 questions from the floor, and also we will choose one from the live Twitter feed, which is up on screen. And now I would like to invite Dr. Tim Evans, who also needs no more introductions, Senior Director of Health, Nutrition and Population of the World Bank Group, to the stage. Dr. Evans will react to all the 3 questions, and he will also present closing remarks. Are you ready to ask your questions? It will be by a show of hand. So please pose your questions. Be ready to pose your questions. Okay. Great. 2 women asking questions. I like that. Please state your name and your organization and your question. Thank you.
Thank you very much for this exceptional multi-stakeholder panel. My name is Barbara Bultz, Global Development Impact. I also tweeted a question, so I'll just repeat it. I'm very interested, how can we accelerate incentivizing both the private sector engagement and the domestic financing, because as we know, these 2 sources will probably be the major sources to help us achieve universal health coverage by 2030. Thank you.
Thank you. And our other question from our colleague from ILO.
Thank you very much. My name is Xenia Scheil-Adlung. I'm from the ILO, the Health Policy Coordinator. And I have a question to the panelists that spoke on out-of-pocket payments and monitoring them. My question is, out-of-pocket payments are good if they go down, but the context must be okay. The context must be universal health coverage. If they go down because there's no health worker, there's another context. If they go down because people are too poor to pay for them, they won't be captured in this monitor, in this indicator. So my question is, how will the poorest of the poor who fall beyond or below the indicator be captured in this monitoring framework, and how will this be interpreted in the context of Sierra Leone, where out-of-pocket payments went up and down? Thank you.
Tim, you have those 2 questions? And now please allow me to read the Twitter question that was selected. It is from Barbara Bulk. She asks, how can we incentivize better both private sector? Oh, okay.
2 for 1.
2 for 1, yes. So, Tim, would you like to take on those 3 questions and also provide maybe quick closing remarks? Thank you.
Yes. There were actually only 2 questions because Barbara is here and she's also live in the Twitter sphere.
Oh,
sleight of
I
hand.
see. Yes, of course, then we can take on a third question.
Yes, I'm a stowaway. I'm Boris Engelson, that's my name, and I am a journalist freelance who was possibly accidentally or by mistake invited to this panel. So I have 1 question and a half. First, what about school, even primary school, and the army as a first entrance point for the public for medical, for health education and involvement? And my half question is, how are you going to deal with the poor countries when the rich countries are in an increasing mess about the health system every day?
Thank you. So there you go, 3 questions.
Great. All right. Well, thank you very much. And first, let me begin by thanking our panelists, who I think have given us an exceptionally sort of rich tour of the landscape from the imprimatur of a minister managing a very successful system to those that are involved in stewarding those systems in various countries, to the private sector as a critical part. I thought the GSK representative here was modest. They've just scored first place in the Access to Essential Medicines Index this year, which I think is a really befitting honor on the private sector. To our bilateral Irish and Australian civil society foundation, and not the least, the multilateral community. We had, I think, some very nice reminders that it's very important to escape the tyranny of external experts. Had Thailand listened to those in 1997, 98, 99, who said, in fact, it was too difficult and not the right time, then they may not have moved ahead with those ambitious reforms, which we all look back on now, 15, 16 years later, as one of the reasons why there's so much promise. And in fact, there's no good time to start. It's simply time to start. The case for UHC is absolutely overwhelming. It's clear, first and foremost, that we won't achieve our most important SDG, which is to eliminate extreme poverty, if we don't address this issue of the way in which healthcare is financed. And let me partially answer one of the questions, which relates to the importance of private sector. The most important and inefficient and inequitable form of private financing we have in most health systems is by private citizens out of pocket when they are ill. We sometimes forget that that is a form of private expenditure. It's not only a form, it is the most popular form. And there isn't a shred of evidence anywhere that suggests it has either efficiency or equity dimensions. So if we look at incentives, the incentives are all towards how do we create prepayment and pooling mechanisms around which societies can then understand how to allocate resources according to need, which then provides the opportunity to see the benefits of frontline services and community health workers and essential packages. But if the primary form of financing remains out of pocket at the time of illness, that opportunity for rational allocation to meet needs most effectively is eliminated. So I think that this is the incentive. The incentive for pooling private expenditure is to move to a system where we can better meet the needs of the entire population with allocation efficiency, as we call it in the more technical circles. But it's not simply that we will eliminate extreme poverty. As the DG Chan said, this is a great insurance against the shocks that we are increasingly faced with, the uncertainties. And here, there is a question up on the screen about what if we reach a tipping point in climate change? Yes, that's another type of crisis, as are severe outbreaks or earthquakes. And if systems are prepared to cover populations in the context of uncertainties, then they'll program in surge financing and the mobilization of the workforce. Those are things that can be done much more effectively in the context of UHC. But it goes on beyond that, because it's not simply that we're preventing people from being impoverished or that we are getting greater security against shocks. It relates to the fact that, in fact, when we organize our financing for the healthcare sector this way, economies grow faster. And Thailand is perhaps the best example. Thailand made the tough decision to move towards prepayment. And what they found through a study conducted by one of the most trusted multilateral agencies with the initials WBG, World Bank Group, right. But a very thorough study. By the way, those experts that ill-advised the government also had something to do with the World Bank Group. But in their study, they found that with the Universal Health Coverage Program, savings rates went down. And that's because people didn't have to carry a big wad of cash in their pocket for that time when they might fall ill or someone in their household might fall ill. And so instead of keeping that in the pocket, they actually were able to spend that. Consumption went up and the economy grew very importantly. So these are some of the links to the macroeconomic architecture that are extremely important in the context of UHC. We heard from David about health workers, that in fact, if we look at the growth of the health economy and the numbers of jobs that will be added to the economy through the health and social sector, that in fact this is an incredibly important source of decent, and he didn't mention, but I'm sure he would, gender-friendly jobs. When we look at the gender composition of the health workforce, we see a disproportionate employment of women, and increasingly. So these are things that ministers of finance and employment would love to see. And in fact, when we quantify this, as we have in OECD countries, the relatively rich countries, and we show the total share of employment over time, it's grown from 8% to 10% in a 15-year period. That 2% growth in the social and health sectors reflects 60 million jobs in that economy, in those economies. That's a lot of jobs in those companies, which is which is evident of the increasing importance of the health and social sectors as decent and important players. So, with an overwhelming case, the question is, well, how do we implement? And I think we've heard a number of really very important nuggets of wisdom from the revealed experience on the panel tonight. And I would summarize these as I tend to do in an alliterative fashion. And first and foremost is that UHC requires that systems respond to people's expectations and aspirations. This is not something that is being forced on populations. Increasingly what we see is that those expectations and aspirations are demanding that basic coverage, that right, and that entitlement. The second P is that it is dependent on practitioners. And these are practitioners, the health workers. And it's not just the numbers. It's as Dr. Suet likes to remind us, these have to be qualified health workers, not only in the context of skills, but also in spirit and commitment, and also savoir-faire. They need to be able to be seen to lead change and direct systems in the way they need to respond. The third is that, and I was grateful for Jeanette bringing this up, that we have to have policies that not only deal with the present, but also the prospective future. And in that regard, the demographic transitions that are leading to increasing numbers of aged individuals, of which some of us are rapidly approaching, we think all health systems should be anticipating our needs. But it's the reality that policy sometimes looks backwards rather than forwards, and this, I think, is characteristic of systems that will be better prepared. Fourth, it's a whole of society effort, and therefore we need a plurality of players. And this is the multi-sectoral issue, education, the military, those are entry points, but also the public-private mix and the local global. And increasingly what we're seeing is that the interdependency of global labor markets are such that we can't consider the national health system as a singular island in the global health landscape. And finally, and perhaps most importantly, it requires political will and leadership from the top, the very top, and that needs to be continuously reaffirmed. And as we've seen in Thailand, that political will has transcended, I think, 5 or 6 different regime changes, and therefore is absolutely fundamental to sustaining the cause. We've heard that in 2016 there were some successes, and if any of you are concerned, WHO and the World Bank will be from now on monitoring your progress and telling you how well you're doing on UHC according to the 2 measures. Certainly a step forward. There is the launch of UHC 2030, which is part, I think, of the mobilization that we want to really nurture in moving forward. But we've also heard that conditions are not ideal. And I think here, if we're really going to act with ambition, we have to remember that although conditions may not be ideal, our UHC ideals are not conditional. So with that, I am going to thank again our panelists for excellent contributions, our questioners for questions that were well beyond my ability to respond off the cuff, and thank the clock for finishing session in such in a timely way that I won't have to respond publicly to those questions, but I'm very happy to talk with the individuals who voiced those questions. Thanks very much.
Thank you very much, Dr. Evans. Thank you very much to the panel. And thank you from the audience for your patience, and to Barbara Bulk for asking one question but twice. You've outsmarted the system. I know I'm standing between a long day and your cocktail, so I just wanted to conclude by saying today is a celebration for all of us working in UHC. We have come a long way, but the road ahead is still very long. So we have to dare to transform and act with ambition. Again, thank you for attending this event, and I invite everybody to join us at the cocktail reception, which is just outside. Thank you.